شكرا. اسفين على التكنيكال ايرور بس الحمد لله اشتغل بالاخير. So it's mainly specimen retrieval. إذا عملت laparoscopy وطلعت specimen كيف تطلعها برا من الابدومن. So all my patients with laparoscopy I put them in lithotomy position, clean all the way to the nipple line. عمرك ما بتعرف شو بصير باللابروسكوبي. As a kind common tips, organize your table at the start. So put all the cables one side, camera, gas cable, the light cable, put them one side, keep things nice and tidy. And on the other side, you put your active instrument, whatever energy or instrument you use, monopolar, bipolar, harmonic, ligature, it doesn't matter. Typically when somebody calls me for laparoscopy and I go and I see what we describe as a spaghetti effect, you find all the tubes all over and you don't know which is which. With opening, I didn't use Veris needle for the last 12 years or so. Always I recommend to do Hassan technique. This is a very nice way to do it. 2 cookers, you hold the umbilicus, you invert it, and then you take a knife and you don't incise, you stab the knife. Don't be afraid. And nothing will happen. Even if the woman have 3-4 midline laparotomies, you'll be fine. You go there and you see a little bit of yellow in the middle, and that's where you cut the umbilical ligament. You hold the scissor only with the index and thumb, not with your palm, so no force. You push it in and you're already in, and that's done. Very simple entry technique. You put your port, you inflate the gas, and here you go. And that's the end result. Even with this obese BMI 50, you cannot even see the scar intra-umbilical. This is kind of view doing laparoscopy. So if you have the facility to have to screen, always advisable. You need to mind your back and your shoulder. You don't need to be kind of twisting this way. Your assistant can see your active device with the right hand and the other assistant with the left hand. This woman had cervical cancer treated with radical hysterectomy radiotherapy, and then on her scan there is a suspicious disease on the PET scan. So we took a biopsy. The easy way to retrieve these small specimens is very cheap. Just take a glove, cut the finger, push the finger in the abdomen, and put the specimen in the finger. Very simple. And then you can take it out through the 5mm port. Always try to avoid using any 10mm port. Put it in the 5. You pull. Don't be afraid. Nothing will happen. It's not going to rupture. I did it many times. This is another woman with endometrial cancer having a sentinel lymphadenectomy with the node on the left-hand side, something similar to what we showed yesterday. You dissect the lymph node. Nice and easy, clear view, no bleeding, no blood. And the same, you know, this is a small specimen. You can still put it in a glove. This is the sentinel node from the other side. It's much smaller. And I think both of them, you'll be able to put them in the finger glove. It's very cheap. You know, you don't have to pay any money for that. You don't have to buy anything. You put in the glove, and again, you retrieve it through the 5mm port. Now, one of the issue, if the specimen is big, like the lymph node from the other side, sometimes you find it's very difficult to deliver through the 5mm port. So the choice is to put a 10mm port, which I strongly advise you not to do. But the easy tip is just push it through the umbilical port. And I'll show you how to do that later on the video. This woman had a para-aortic lymph node. You see the aorta there on the left-hand side, and you see the ureter moving on the background. I have a pointer. Here you go. So that's the ureter there on the abdominal part of the ureter. That's the IVC, inferior vena cava, and the aorta. And again, you dissect the node, and this is a quite small, little node. You can put it easily in the finger and retrieve it through the umbilical port. Now, so for these little small specimen, endometriosis, exciting endometriosis, a small peritoneal disease, a cerebral lymph node, all these specimens you can deliver them through a finger bag through umbilical port without the need to add any cost to your surgery or your laparoscopy. The other axis for delivery is the vagina. You can deliver anything through the vagina. So with a simple hysterectomy for benign reason, for endometriosis, dysfunctional internal bleeding, even for fibroid up to 15 centimeters in size, you can deliver them easily through the vagina. You can't deliver omentum, you can't deliver anything. One day I delivered a kidney through the vagina. It was a combined procedure with the urology team for renal carcinoma. And they want to make a scar. I can't understand it. These guys, they do a big laparoscopic surgery and then they do a scar to deliver the specimen in colorectal. So you can't deliver through the vagina anything. The other trick is if you're suturing intra-abdominal, the needle is usually too big to come through the 5mm port. So very simple trick is bend the needle, very simple. Hold the needle from 2/3 each side, bend the needle, and you can take it out from the 5mm port. You save yourself a big 10mm port. Now, if your specimen is a little bit bigger and it doesn't go through the 5mm through the finger, this bag, they have different names. So this one we call bird bag. It's very simple. You push it through the umbilical port. So again, no need for the 10mm port. You put your specimen and you deliver it through the umbilical port. And you know, with the umbilical port, you can use a 5mm camera to see it. But also you can, you know, just push it through the umbilical port and you'll be fine. So this is the way you look in through the abdomen. So you know, you put the umbilical port and the upper 5mm port in alignment, and you just push your bag through the 10mm port, the intra-umbilical port. And it's very easy. You don't need to do anything. And here you go, it's out. So you save the patient to go through the 10mm port. All the complication I saw, it really comes from the 10mm lateral side port. So this is showing the bag from outside. This is how the bag looks like. So one side is much longer than the other side. And there's a point to do it this way. And when you put it inside the abdomen, to align it in a certain way to make it easy to retrieve the specimen. Just push it through the umbilical port, easy. You don't need to do any other extra port. So this is how you deliver it in the abdomen, and I'll show you how to take it out. This is a patient has a big endometrioma. Again, put it in the bag. This is the wrong way of doing it. I just show you this grab to show you the wrong way of doing the bag. It makes it more difficult, and you spend some time, couple of minutes, trying to put the specimen in the bag. There's a little trick for this bag, which I'll show you in the next clip. So this bag, always take it this way and push it in the pouch of Douglas. So antever the uterus, hold the bottom of the bag, antever the uterus, put it in the pouch, and it is open for you. You see how the mouth of the bag is open? And it's very simple. You can take any specimen and put it in. And this is the reason why you have a short and a long. So the long side of the bag should be always posterior. So when you put it that way, it'll be very easy. Otherwise, you'll be doing this for minutes and minutes, and that's what my fellow, they usually do when they start training. They try to do things quickly, but they spend more time doing it. Do it this way. Put it in the pouch, open the mouth of the bag, and then very simple. Here you go. Just drop it, and it'll be in. So this is kind of one of the tricks for this bag. Just always put it in the pouch of Douglas, make things really easy. This is another example of a woman who had bilateral salpingioophractomy for risk reduction. Again, put it in the pouch of Douglas, mouth is easy opened, put your 2 ovaries in, and again, you don't need to do any extra incisions, any big lateral incision. You still have your 2 5mm incision laterally, and you take it out. This woman, she doesn't have a uterus, but still, you can use the pouch of Douglas to put the bag in it, and the mouth stay open. And you can put the specimen quite easily. So too many examples to show you about it's why it's very easy for these small size specimen, simple cysts, risk reduction, bilateral salpingioophractomy. You can do it very, very easily. Again, the trick, just remind you, always put it in the pouch of Douglas, open the mouth, leave it open, drop the specimen, and out. Now, if the specimen is a little bit bigger than this, then the bird bag is not going to help you. You know, the mouth of the bird bag is only 5 centimeters, so you need something bigger. This is an endo bag, which the size of it is 15 centimeters, so you can put really a big specimen on this bag. Now, this bag is designed to come with an introducer, and you need a 15, not a 10, a 15mm incision to put it in, but I don't do it that way. I don't like to do a big incisions. So the same, you put it in, you use the pouch of Douglas, you put whatever specimen you want in, you hold the thread, you pull out, you close it, and the same technique, you push it through the umbilical port, and it will be out. So you push it through the umbilical port, exactly the same technique before. It's another example with a fibroma of the ovary. So push the bag in, open it, push it in the pouch of Douglas, take your specimen and put it in. And the same. So you can close the bag inside, but the easy trick, which I'll show you next, is just take the thread out. So don't try to struggle to close it inside. Take the thread out and just pull on the thread. Very simple. It doesn't take time. And that will close the bag. It'll be completely tied and sealed. And then the same technique, align the two umbilical port with the upper 5 millimeter port. Put them on one line, push the bag through the umbilical port, and it's out. And once it's out in a bag, so even if it's a cyst, even there's a risk of malignancy, you're happy, you're confident it's contained. You rupture the cyst, you suck the fluid, become way much smaller, and you take it out. So this is how the bag should look like. This is the applicator. And as I said, it usually comes with a port 15 millimeter. I don't do it that way. Just modify that technique. Take it out, cut the thread, fold it in itself, and instead of having an extra unnecessary 15 millimeter incision, you push it the same way. You push it just through the umbilical port, and you'll be fine. And that's it. It's in. And once it's in, you can open it the way we did before. This is a little bit bigger cyst, 12 centimeter cyst, and it's exactly the same technique. One of the tips is always move your specimen from the pelvis before you open the bag. Because once you open the bag, if the cyst underneath it, then you have to close the bag, find the cyst, and then put it in the bag. So always use the pouch of Douglas to fix your bag. Otherwise, it will be mobile all over the place, and it doesn't help. So open the bag. You know, we try to, if you saw that in the background, there was a PERT bag. We tried to put it in. It didn't work, so we used this one. Close the bag tightly from outside, push it through the umbilical port, and you deliver it nice and intact. So you don't worry about risk of malignancy, even if the CA125 high. This is a bit more complex. She had hysterectomy, ruptured appendix before, a lot of adhesion. It's a long clip. I can't share it with you all, but you can see the cyst is adherent to the rectosigmoid here at the back. So we did a good bit of adhesolysis. We delivered that until the cyst completely was separated from the rectum and the bladder. And again, even the uterus is not there, you can use the pouch of Douglas to open the bag, put the specimen, and take it out the same way. So if you notice, I always use the upper port, the upper 5 millimeter port, to close the bag and push it from there through the umbilical port. Now, this patient is very interesting. She was young, 35. She came from a fertility clinic with, you see, a disease everywhere in her pelvis. We took a biopsy from it, and it was a low-grade serous carcinoma. She was very young. Her upper abdomen was clear, so we decided to progress with keyhole surgery, laparoscopy. She has a good bit of disease on the pouch of Douglas, a big nodule in her rectum, but that did not stop us from doing her surgery with laparoscopy. So you can see here in the background all her peritoneum in the pouch on the side of the pelvis, around the bladder is completely removed. The ureter here is completely naked. She had a full ureterolysis. You can see the external iliac artery bilaterally. And then when you see the bladder here is completely naked from the peritoneum, because peritonectomy is very important in women with low-grade serous carcinoma. And then we have to make the decision here. She had a disease, she has a nodule on the rectum, and what you're going to do with it. Are you going to leave it, or you're going to remove it? Leave it is not really good news, because low-grade serous cancer does not respond to chemotherapy. So we decided to excise her rectosigmoid, which is still doable with laparoscopy. You make a hole in the mesorectum, you apply this device, which is called GIA, gastrointestinal anastomosis. Again, it comes in two sizes, 5 and 10. I use the 5. I don't like to use 10 millimeter ports. It just causes hernias, pain, and too much trouble. You apply it wherever you want to apply it, at the sigmoid. It's very simple, easy. You cut and you take another device, and on the other side of the rectum, just behind the cervix, you apply the same device at the lower end of the rectum where you have the rectovaginal septum. And again, once you cut, you drive the device and it has a knife within it, so it anastomoses and cut at the same time. And that's the vagina with a clean pelvis. So again, we use the same 15 millimeter bag, exactly the same technique. So all that specimen will be delivered easily through the vagina. So you open the bag. If you notice, there's 4 instruments in this case, a bit more tricky. So it's not like the early cases with only 2 instruments because you need assistant, and always your assistant if you need them. So with the bag, the specimen inside, you make sure you close that bag tightly. Exactly the same technique. You take it out through the port with your hand, you pull out and tightly close, and then you push this through the vagina. And the plastic tube you see it in the vagina is something called McCartney tube. We use it for hysterectomy and to maintain the pneumoperitoneum. The trick here is just take your time, no rush. You know, the more you pull, sustain the pressure, it distends the vagina slowly and gently. Be patient. You don't want to do it quickly, otherwise the bag will rupture, and you don't want to do that. And the specimen eventually, just be patient, take your time. Remember the obstetric bit, put the legs up, lithotomy position. Sometimes that maneuver, when you turn the wood screw maneuver, rotate the specimen and it will be out. And whatever you have in the abdomen, you see there's 2 swabs. You can deliver them through the vagina. This woman, she had a full omentectomy as part of her surgery. So also you deliver the omentum through the vagina. Vagina, if it's opened, it's really a good access to deliver whatever kind of specimen you have in the abdomen. So the big omentum, all her omentum has to come out, and it's easily coming through the vagina. Again, swabs come through the vagina, needles come through the vagina, as long as the vagina is opened. And then you anastomose the rectum to the sigmoid. Again, you do that totally laparoscopy, which make a huge difference for the patient's recovery. She was home 2 days. You see the ureter here on the right-hand side is completely uteralized all the way to the trigone. So just be careful when you do anastomosis. This woman, she was discharged 2 days after the procedure of having posterior exentration laparoscopy. She's 4 years since that surgery, and she's still well. She was 37, now she's 41, and she's doing very well. So that's the final specimen, which you deliver through the vagina in that 15 millimeter bag, and that higher disease on the rectum. So you can achieve a lot through minimal access surgery if you train to do it. Now, this is a little bit bigger specimen, so we go to the real stuff. She had rudimentary uterus on the left-hand side, no tube ovary. She has a big fibroid in the uterus, and she has a big lesion. And honestly, my fellow did this surgery, not myself. And he only spent with me 12 months. So that was his last surgery before he left us. So he did all this by himself. Absolutely, I was holding the camera for him. But it's a big specimen. You can't put it on that 15 millimeter bag. So we have this special bag, which really not designed for laparoscopy. This is called isolation bag. We use it for laparotomy to isolate, to put the small intestine in the bag to keep it isolated, nice and moist. But I come up with the idea I can use this bag for bigger specimen. It's really a huge bag. You can put really big specimen on that bag. But again, it's not designed for laparoscopy. But host it so you can use whatever you can use as long as you know how to do it. So you put that specimen, and again, it's a little bit more tricky because it's not designed to be used laparoscopy. But still, you can close it. Take your time, patient, be tightly closed. And then again, in this case, she had hysterectomy, so the vagina is opened. And remember, if the vagina is opened, it's your best preferred choice to deliver these specimen, whatever the size of these specimen. So again, you see in the background there the McCartney tube. You push which is the plastic tube in the vagina. You push the specimen through the McCartney tube and then out through the vagina. And once it's in the vagina, once it's in the bag, it's isolated. So that is the specimen in the bag. And then somebody will be between the patient's leg delivering the specimen. And again, once in the bag, it's completely isolated. So you can rupture the cyst, you can drain the cyst, you can tear it in pieces. It doesn't really matter. It is contained. You're not gonna improve overall prognosis. She has a fibroid, so I apply a screw in the fibroid, the one we use for my eyes on the screen there to make sure I'm not outside the bag, and then the specimen is out. And now how you can introduce these, this is kind of the final picture for that case. And again, as I said, this is done not by myself, by my fellow, and it looks, it's very nice and dry, not a single drop of blood. Now this is the bag, this is how it comes. How you can push it in the abdomen, you can put it through the McCartney tube, and the McCartney tube is, we always use it for hysterectomy. Or you can do it exactly the same trick I showed you earlier with the 15 millimeter bag. Fold it in itself, put it on artery clip, and then simply put it through the umbilical port. A simple trick, very simple trick. And it's a huge bag. I'll show it to you later how's the size of this bag. It's really massive. So you can put whatever you want to do. So this is how you put it in the abdomen, either through the vagina, if the vagina is open with hysterectomy, or through the umbilicus for this one, who's a young lady with a big cyst. That's her CT scan on the right top corners. So she had a few symptoms. CA125 was normal, and she insists she doesn't want to have a big midline incision. She was more worried about the beach and wearing bikini rather than incision. So after discussion, we agreed to do it with laparoscopy. So, you know, that bag really can accommodate whatever specimen you have. One of the tricks here, once you put the specimen in the bag, if you ask the anesthetist to put the patient head up from lithotomy, from Trendelenburg position, it will help you. The specimen just go easily through the bag. And again, you take your time, close the bag, make sure it's tightly closed. In this case, she did not have a hysterectomy. She's very young, so we cannot deliver it through the vagina. So the easy way to deliver it is through the umbilicus. So the same trick, align the 5 millimeter port and the umbilical port, same line, push it through there, and you take it out. And look how huge is that bag. So you can really put whatever specimen you want inside. And again, once it's out, it's contained, safe, you rupture it, suck all the fluid, and then the specimen become way, way much smaller, and you can take it out quite easily. And again, it's nicely contained, no contamination. Try to remove it intact, but even if you have to cut it in pieces, it's fine. Just make sure you inform the pathologist it was removed intact in a bag, because that makes a difference for staging. And that's the final specimen outside. So thank you very much. I hope you enjoy the presentation, and I hope you learn a few little tricks for future. Thank you very much.
دكتور فراس شكرا لك وختامها مسك. إن شاء الله نلتقي فيكم السنة القادمة، بس بالعدد يزيد شوي بدنا.
شكرا للجميع على سعة الصدر، وإذا أخفقنا بإشي إحنا نعتذر منكم، وإن شاء الله يعني نوعدكم في الهلال الأحمر القدس إنه يكون هذا تقليد دائم، وإنه يكون القدس تكون منبر لتجمع أطباء النسائية والتوليد في الضفة الغربية وفلسطين، ونوعدكم إنه نستضيف زي ما استضفنا السنة هاي باقة من أفضل وأجمل المحاضرين في العالم، كلهم باسمه ولقبه. شكرا لكم وحضوركم وعلى عنائكم، والقدس سعيدة بوجودكم، وإن شاء الله دائما مع بعضنا، وبنقدر نطور مع بعضنا تعاون في أشياء تانية غير المحاضرات.